and it's a pleasure to welcome the next speaker, Professor Ilya Dashi, the former Dean of Medicine and Biological Sciences at Brown University, who will give us an insight on why we in Europe live in heaven, because access to fertility care in the US is quite different. It gives us an insight on the realities of the public and private sectors.
Thank you very much. And thank you, Andrea, for the kind introduction. And yes, for grasping the essence of the issue. We will be speaking today about access to infertility care in the United States, especially the realities of the public versus the private sectors in this country. And while this presentation is focused on the United States, there are lessons and comparisons that can be useful relative to other nations who are struggling in their own different ways with this very issue. To those of you who attended the American Society of Reproductive Medicine meeting in October, I apologize in the sense that I did present a much broader outline of this issue. And so for those of you who were there, I apologize for the repetition. There are many barriers to access, of course, but in the final analysis, it seems that the most critical barrier is the economic one. And what we mean by that is a barrier that I think of as the final common pathway, the rate limiting step, if you will, or the door through which ultimately everybody has to go through. In more tangible terms, we are obviously thinking about a combination that comprises the very high costs of assisted reproduction that are very frequently juxtaposed against widening income disparities and against the backdrop of limited underwriting options. In the United States, at least part of the challenge is the fact that we have failed as a nation, as a people, to define infertility as a disease as distinct from the definition of the World Health Organization, for example. The ASRM, our leading professional society in reproductive medicine, did proceed and define infertility as a disease as far back as 1993, and then affirmed and reaffirmed the same in 2008 and 2013, respectively. However, no other credible public or private entity followed suit. For their part, the Congress of the United States and the Supreme Court of the United States characterized infertility as a protectable condition and as a form of disability, respectively. This hands-off approach to the definition of infertility and to the underwriting thereof is quintessential American in many ways, one which draws on a rich vein of libertarianism, which, as you know, strongly defines our national identity and, in particular, our Constitution. What is more, the pluralist democracy that is the United States, unlike the social democracies of Europe and beyond is far less embracing of notions such as big government or cradle-to-grave coverage, not to mention national health insurance, which we lack and do not expect to have in the foreseeable future. Lacking the necessary legislative, judicial, cultural, and political support necessary to assure the underwriting of infertility care in America, not to mention the failure to define infertility as a disease, the net effect is that neither the private nor the public sector in the United States bear any formal responsibility for the underwriting of infertility care. It is left to care for itself, if you will. It is dangling out there without any governmental intervention on the one hand or private sector intervention on the other. Perhaps one of the most striking illustrations of this bizarre state of affairs is the so-called Patient Protection and Affordable Care Act of 2010, also known as Obamacare, wherein the provision of infertility care was deemed to be too costly and therefore was not incorporated into the statute as a so-called essential health benefit. And so it should come as no surprise to anybody that the underwriting of infertility care in the United States is characterized by high under- and uninsurance rates, high out-of-pocket expenditures, absent public payers and support, very limited private payers, as we will discuss, and an interesting arrangement characterized by 15 infertility state mandates, which leaves out all the other 35 states of the Union. This state of affairs has been characterized by many as dismal and by some as socially unjust, because the net effect is, or at least so it would appear, that family building in the United States has become a function of one's economic prowess. In a word, if you can afford it, you can have it. If you cannot afford it, you will not. This particular facet of our circumstance is poignantly illustrated by the latest national survey of family growth of the National Center for Health Statistics, according to which the ever use of infertility services in the United States was highest among non-Hispanic white women with higher levels of household income and higher levels of educational attainment. What the net effect is, of course, is a substantial divide between the public and the private sector when it comes to the underwriting of infertility care. None of the public assistance programs of the United States, Medicaid, Medicare, the Federal Employees Health Benefits Plan, the Veterans Administration Organization, and the Indian Health Service, none of them have addressed in their history the possibility of infertility care, let alone the underwriting thereof. The one commendable and unusual exception is TRICARE, which is an organization that cares for active duty beneficiaries, which number approximately 9.5 million. The military, or the Defense Department in this case, have specifically undertaken to subsidize assisted reproduction for all of our soldiers who are currently in active service, which resulted in approximately 1,200 ART cycles in 2013, during which active duty personnel had to engage in an out-of-pocket cost of less than $7,000 per cycle. In addition, TRICARE fully covers the costs of assisted reproduction to a limited few, which it defines as wounded warriors, that is to say, severely injured service members in the line of duty whose reproductive function has been severely compromised. Interestingly, the Pentagon and the Defense Department have recently offered to pay for the storage of eggs and sperm for young troops in anticipation of a potential injury in the future. This particular initiative is still being explored. It certainly has not been enacted into law as yet, but it's interesting to note that the Defense Department and the military in general, although sometimes viewed as a very conservative and slow to adapt organization, has in fact been at the forefront of many social issues in the United States, and reproduction, it seems, is no exception. Multiple legislative efforts over the years to add IVF benefits to the Federal Employee Health Benefits Plan have consistently failed, going all the way back to 1987. The Veterans Administration, which is home to 10 million veterans, has found itself in a similar situation, which for the last quarter century has precluded the Veterans Administration from providing any form of infertility care, let alone assisted reproduction, due to a law that was passed in 1992. And I quote, "The Secretary of Veterans Affairs may provide to women the following healthcare services, not including infertility services." Repeated legislative efforts to underwrite infertility care, at least for injured veterans who badly need it, have been repeatedly blocked by conservative members of Congress, the sponsor of these efforts almost single-handedly having been Senator Patty Murray, who is a senator from the state of Washington and who is a Democrat by her affiliation. Finally, just before this meeting, an amendment proposed by Senator Murray was finally enacted into public law on September the 29th of this year, which will allow the Veterans Administration to finally provide care to injured veterans. And mind you, we are talking about a very small number of individuals, well under 100. And yet, to reach this point, it took us 6 or more years of intense confrontational debates in Congress before we accomplished this modest feat. But there is a price to pay, and that came about in July of this year in the context of the appropriation process for the military and for the Veterans Administration. On that occasion, a Republican representative from Maryland, Andy Harris, a physician, successfully sponsored an amendment which would preclude the public funding of IVF either in the Veterans Administration or in the Department of Defense, if there was ever any form of embryo destruction. In a sense, linking the public funding of IVF to a prohibition of embryo destruction. This is a copy of the actual original draft statute, replete with handwritten annotations, the core of which requires that the discarding or destruction of viable human embryos before embryo transfer would be incompatible with the funding of such programs in the United States. We don't know yet whether this amendment will in fact become law, but we do think of it as an ominous precedent because it links the clinical practice of reproductive medicine to some difficult principles that would be very difficult to comply with in the context of our day-to-day practice. However, if it does come to pass, beneficiaries of the Department of Defense or the Veterans Administration will likely be deprived of the benefits, for example, of cryopreservation, or for that matter, just freezing of embryos in the context of the standard practice of reproductive medicine. On the private side of the equation, most Americans are covered by so-called self-insured employer-sponsored plans. Approximately 60% of Americans who are privately insured receive their coverage through their employer. We have had the privilege of receiving some unpublished survey data on over 1,000 employers from Mercer, a human resources consulting firm, which showed that the size of the employer is a major determinant of the inclusion or exclusion of IVF benefits from the benefit package. As you can see, mega employers that have 20,000 employees or more are more likely to include IVF in their benefits package than smaller counterparts. This type of data appears to hold true also for the non-IVF component of the benefits, such as a visit to the reproductive endocrinologist, attendant drug costs, or superovulation IUI. The larger the employer, the more likely these benefits are going to exist. The Mercer data also revealed that employers headquartered in the Northeast of the United States are more likely to include IVF in their benefits package than Midwestern, Southern, or Western counterparts. Here again, the same conclusions hold true for the non-IVF component of the benefits package. Interestingly, in the United States, in the last few years, several major employers have offered to freeze eggs for their female employees, beginning with Apple and Facebook, later on joined by Citibank, JP Morgan Chase, Intel, and others. According to Mercer, this benefit is beginning to take hold, albeit in a very modest fashion, yet again in a very geographically constrained fashion. Lastly, I'd like to mention a hybrid arrangement which characterizes the underwriting scene in the United States, a combination of private and public insurance that is represented by the so-called infertility mandates. These mandates are essentially state laws, limited to a few states, wherein the governance of that state dictates to resident insurance companies and in fact requires them to cover IVF whether they wish to or not. 15 states have legislated such laws, and so in 15 states a modicum of infertility coverage is offered. These are the 15 states that are currently the beneficiaries of such a law, although I will point out that the ground rules between states vary widely. Some states reject IVF benefits outright, yet others provide them. In total, no more than 6 states out of the 15 actually provide meaningful IVF benefits, although modest ones. Which brings us to the end of this brief presentation, which hopefully gave you a sense of the challenge we have here in the United States to underwrite infertility care in general and assisted reproduction in particular. In fairness, I should mention that this is not pathognomonic or exclusive to the reproductive arena. We have other major issues related to uninsurance. Many Americans remain uninsured. They are mostly poor, they are often immigrants, and sometimes none of the above. In a way, what we see in the reproductive arena is a reflection of the same, although it is amplified by conservative and libertarian concerns about reproductive freedom and reproductive rights in general. Thank you very much for the time and the opportunity, and I appreciate